Hi, this is Brian Wormers recording a lecture on staffing for NUR 451, Management, Leadership, and Professional Issues. So what is staffing? Staffing is finding people to work. So it's a process of identifying, recruiting, hiring, and placing the right people with the necessary skills and qualifications into suitable job roles within an organization to meet its operational needs. Right, just rolls off the tongue, and that's so simple. You're finding the right people to do a job and to be where they need to be. So what do we need to consider with that one? So for appropriate nurse staffing, we need to think about why we do it. Why don't we just have bare minimums? Why don't we go suboptimally? Well, what we found is that if we've got appropriate nursing staff and we are filling these roles appropriately, then you've got improved patient satisfaction, increased quality of life, reduction and decrease in medical and medication errors, decrease in patient mortality, readmissions, length of stay, decrease in number of preventable events, decrease in patient care costs, and decrease in nurse fatigue. And so all those things are great, for lots of different reasons. We want better outcome for our patients. We want better outcome for our nurses when we look at nurse fatigue. We don't want to be making medical errors. That's not good for nurses. It's not good for patients. It's not good for the hospital. And of course, the hospital is looking at their finances, and if we can keep costs down, prevent events and lawsuits from all these type of things, have increased quality of life, increased patient satisfaction scores, all these things will lead to hopefully higher profits and better revenue, and decrease expenditures if we don't have to pay out patient care costs and lawsuits and those kind of things. So staffing is extremely important, although very difficult to do. So what are some of the ways that we do this? Well, two big things: fixed staffing or flexible staffing. Fixed is every day we are going to staff 7 nurses on this unit, and that's the way it's going to be. Those roles tend to be very I would say very similar, so the days to days function about the same. Nursing homes might be like this, or sometimes it's, to some extent, even ERs. It's like this: these are the nurses that you've got staffed today. And that's going to vary depending on nights and weekends and holidays and different things like that, but they start off with, this is how many you get. More flexible staffing models are going to be dependent on things like number of patients, acuity of patients, number of other people to help. So your amount of nurses might depend on your patient care techs, etc., etc., etc. So what are some of those et ceteras that we're looking at here? So factors that influence this staffing is going to be patient complexity. Of course, an ICU is going to have a higher patient to nurse ratio, with being 1-to-1, 2-to-1, 1 patient to 2 nurses sometimes, as compared to when they're more stable. Number of admissions: how fast are they turning around? Are they seeing lots of people? Is there lots of paperwork? Is there lots of transfers and discharges? Or are things fairly stable? Looking at the professional nursing and other staff and skill levels, if you've got some highly trained people, maybe you need less of them. Meanwhile, if you've got all new staff, maybe you want to go a little heavier because you know that they're not going to be as efficient. Also looking at the level and expertise. And what I mean by that is, if you've got a patient that needs chemotherapy, how many chemotherapy nurses do you have, or how many nurses are trained in chemotherapy that can give that safely and appropriately? What other skills do they need? What's the physical space and layout? If you've got a good layout and a good organization and a system, then oftentimes you can get by with less nurses. If you can't, if it's very isolated, if it's very cumbersome, then you're going to need more nurses and more staff. And then other technical support and other resources, as we're talking about AI now, we're talking about virtual nurses and those kind of situations. Maybe we need less nurses, quote unquote nurses, on the floor, if we've got those other AI abilities. So nursing staffing legislation. So why don't we just make legislation for, all the different states and all the different places? Well, for me, it's not that easy. I wish it'd be like, oh yeah, of course we're going to do this, but who's going to mandate this? And think about all the different units that you've been onto. Oh, well, if you're on a med-surg unit, you're going to have this kind of staffing ratio. Well, not all med-surg units are the same. I've been on some that are much heavier, much busier, depending on what they're all seeing and doing, than some of the other ones. And so within that, I think it's very difficult to have legislation for it. You can say that, yes, we need this. But, to say that, oh yeah, you've got to be 2-to-1 and no more than 2 patients in an ICU. Well, I've definitely been there where we've had 2 nurses per 1 patient. And the patient was just that busy and was on ECMO and was on a ventilator and was needing lots of supports and supplies and equipment and care. And we couldn't necessarily do, I would not have liked 2 of those patients. So while it's great and I want to look out for nursing and staffing, I think it's going to be really hard to get a legislator and somebody to give a definitive answer about, what it's going to look like in this city and how it looks like in all cities even in the state. I think that you've witnessed that. I think you've been on different floors and realized that the staffing is different from from this one to this one. And that could be even in the same institution in the same city. Now think about the variability between the cities, think about the difference in the states, and it becomes a nightmare. And while I think it's a great thought, I think the implementation of this is really difficult. So what do we do if there's unsafe staffing? Well, the first thing is first-person communication, and talk to the charge nurse or talk to whoever assigned this and say, hey, look, this is what's going on, and these are my concerns, and this is the patient's situations, and this is why I think that this is going to be too heavy of a load or an unsafe assignment. With this patient, they're quite active, they're around the corner, I can't see them, we don't have correct monitoring, etc., and talk to that direct person. If that doesn't work, take it to their manager. If that doesn't work, take it up. If that doesn't work, you're going to file a protest. So it'll keep going up that chain of command, but say something. And oftentimes they'll listen to you and be like, oh, honestly, I didn't know that. Or, oh, I didn't know they had chemo today. Or, oh, I didn't know they were going to do this procedure today. And so, and that's how you can help change things. Realize that some places do have different matrices and stuff like that, and they're plugging stuff in, and that it looks good on paper, but when they look at the all those different indicators about the acuity of those patients and the location of the patients and different things like that, maybe it's not as good. So start with just good old communication. Well, that concludes this lecture on staffing. You've all seen it, you've all done it, but realize some of the intricacies of it and all the complexities about what they consider when they're looking at staffing. And look at all the things that, the characteristics of the nurse, of the patients, of the unit, and all those different things.